All right, this is it, the finale. We're going to lock in these algorithms for good. Remember, with arrhythmias, it's all about two things, speed and stability. Let's kick things off with a high-speed blitz.
Heart rate's too slow, patient's symptomatic, first line is atropine. That doesn't work, we're moving straight to the definitive fix, a pacemaker. Next.
Too fast, narrow QRS. Is it regular? Adenosine. Irregularly irregular? That's your classic AFib. Totally different pathway. Think anticoagulation to stop clots. Moving on.
All right, what if it's too fast and wide? You have to assume it's ventricular tachycardia. And the most important question you can ask is the patient unstable? We're talking hypotension, chest pain, confusion. If you see any of that, you stop messing with drugs and you shock them. Simple as that. Synchronized if there's a pulse, unsynchronized for pure chaos. You gotta master the branch point, choose the right weapon, and save the life. Okay, before we go any deeper, protocol demands we hit the official guidelines. Let's be perfectly clear. Our mandatory international medical disclaimer. This content is intended for educational purposes for international boards only. It is not and should not be considered medical advice. You must always consult official guidelines and a specialist physician for any and all clinical decisions.
All right, Sarah, we've nailed down the individual rhythms. But for the boards, the real question is always, what is the next best step? So let's start with that absolute golden branch point in the decision tree.
So, let's define our terms. How do we define an unstable patient?
That's the screaming organs rule, Dr. Collins. The patient is unstable if the arrhythmia is causing hypotension or shock, any altered mental status, acute heart failure, or ischemic chest pain.
And in that situation, we don't have time to wait for meds to kick in. We go straight to electricity. So for tachycardias where there's still a pulse, that means synchronized cardioversion. If they're stable, well, then we've got the luxury of time to climb the drug ladder.
Precisely. Stable means meds, unstable means the plug. Okay, now let's do a deep dive into the bradycardia algorithm. And for everyone watching, please check the resources and official guidelines we've linked down below. So, heart's too slow, patient is crashing, what is our first move?
Our first move is atropine, 0.5 milligrams.
Right, but here is the classic board trap. Atropine doesn't work for third-degree block or Mobitz 2, and that's because the block is just too low in the conduction system.
Exactly.
So in those cases, or if the atropine fails, you move straight to transcutaneous pacing while you're getting things ready for a permanent pacemaker.
Excellent point. That pacing is the bridge to survival. Okay, let's pivot to the tachycardia algorithm, and we'll start with this very specific rhythm, torsades to points. As you can see, it is a specific polymorphic ventricular tachycardia characterized by a twisting pattern on ECG. Now, Sarah, what's the one drug that students always seem to forget for this?
Magnesium sulfate. Even if the patient is stable, the second you see that twisting pattern, you give 2 grams of IV magnesium.
And for ventricular fibrillation, the answer is always unsynchronized shock. That is, defibrillation. It's not synchronized, it's just a high-energy unsynchronized shock. I mean, you can't synchronize to a heart that's just quivering chaos. Outstanding. Okay, last one for the deep dive. The WPW trap. That's Wolff-Parkinson-White syndrome, right? That condition with the extra electrical pathway. We've hammered this home before, but for the finale, say it one more time.
If it's WPW plus AFib, you never use beta blockers or calcium blockers. You use procainamide or electricity. Because if you block the AV node, that shortcut pathway is going to kill the patient.
Perfect. Master the branch, check for stability, follow the guidelines. Okay, Sarah, let's lock this in for good. Here comes the final decision tree.
Slow? Needs a pace. Atropine.
Narrow, needs a race. Adenosine.
Wide. Assume VT.
Unstable. Electricity.
WPW, no blockers.
And finally, links, review. Always review the official links and guidelines. So, Sarah, is the finale locked in?
Locked in, Dr. Collins. Stability first, then the algorithm.
All right, time for our question of the day. In this whole series, what was the most challenging ECG rhythm for you to really master? Was it that tricky Wenckebach waltz, or maybe the Brugada shark fin? Let us know down in the comments. And with that, you have officially completed the Arrhythmia Masterclass. You are now the master of the electrical storm. Make sure you subscribe because we're moving right into our next high-yield series, Infective Endocarditis. Let's keep encoding.